Hello, Professor Andrews. We are so happy to be here. You have a core input to the International Conference on Neuroprotective Agents, both as organizer and as presenter. We would kindly ask you to share your perspective on these multidisciplinary proceedings. So how would you characterize this event?
Well, I think this meeting, it has a lot of the flavor of the meetings that Professor Marzano has conducted throughout Europe over several decades now, and this multidisciplinary approach of uniting neurology, neurosurgery, neurorehabilitation. That's in the U.S. certainly that's becoming back into focus, but for many years those were very separate groups and their meetings were very separate. And this International Conference on Neuroprotective Agents was started, as I think you talked with Bill Slicker, who recently retired as a chief of toxicology at the Food and Drug Administration. It was mostly basic science people and anesthesiologists, and I was working on, being a neurosurgeon, was working on getting more clinicians outside of anesthesia specifically involved. So we've tried to mimic what Professor Marzano has done for decades, and we've now, it's been several decades, that this meeting has done the same thing. So I think where do you go from there is you just try to expand the horizons to get more people from different parts of the world involved. And I think one of the focus of our meeting and meetings in general, and it's great to be here in Romania, is the need to target the treatments to the populations you're working with. The problem in the U.S. is by far the worst. It seems like every new therapy is more expensive, more exotic, and therefore fewer people around the world are going to benefit from it. And so we need to go that other direction. I think in Europe they're much more sensitive to that because of the difference between Switzerland and, the difference between Switzerland and Romania is not that great now, but there's still a bigger difference than just within Switzerland itself. And so I think they're much more attuned to having treatments that are cost effective and not just generating income for drug companies or equipment manufacturers, fancy MRI scans and things like that. Okay.
Your talks mention externalized methods of neuroprotection enhanced by innovative technological advancement and collaborative societal policies. How should the human resource position itself within the context, and where do you think there is a place for improvement?
Well, there was a study done by the Lancet Commission. They have commissions on various aspects of healthcare, the Lancet publication group in the UK. In 2015, it was the Lancet Commission on Global Surgery, and they have data showing that a third of all deaths worldwide are due to lack of surgery. That's 4 to 5 times the total deaths combined of AIDS, tuberculosis, and malaria. And so what that did was kind of the first, it's like a 70-page article, really put into focus the need to expand surgical care. And that's what we've gotten a group of people together. Actually, we started even before that, but this has taken a lot more importance and recognition, and we've had a number of publications. We're a very eclectic audience. We have now 2 former ministers of health in Peru and Pakistan, the new minister of health in Kosovo, one of the previous CEOs of the National Health Service, the head of the International Council of Nurses, in addition to surgeons and both neurosurgeons, trauma surgeons, a very eclectic group bringing together the concept that in a nation, well, take Romania. If you can combine the resources for surgical care, but particularly for mass casualty response. That's what really got this started, was the earthquake in Haiti. And they determined the only group that got there with surgery resources in 24 hours came from Iceland. Apparently they have somebody around the clock, they hop in a plane, and they had an anesthesiologist and a surgeon. But they estimated that 20,000 people died each day the first 3 or 4 days after the Haiti earthquake in 2010 because there were no surgical resources and these were people with fractures. If that had happened in Cluj, they all would have survived. And so probably a third of the people who died could have been saved had there been resources there in 24 hours. And so we're taking that concept and saying, well, in the developing world in particular, whether it's complicated childbirth, acute abdomen, in addition to trauma, there's all sorts of conditions where you need to have surgical resources available on a round-the-clock basis. So you have to incorporate cost-effective techniques, mobile ultrasounds and scanners that can work on batteries. But one of the big concepts is bringing together the civilian and military resources, because the military usually has, in most any country, they have the most sophisticated medical response equipment. And yet, and I was a flight surgeon in the US for several years when I was much younger, and we could have been doing an awful lot for emergency care, but we're separate from the civilian system. And so we're working on bringing that together in places like Pakistan and Chile. Israel, for example, has a very close relationship between the military and civilian medical facilities, but that's not true in many countries yet, and yet it's just very inefficient use of resources. So those are ways you can make a huge difference without costing a lot of money.
All right.
So
yeah, thank you.
That's our goal, and that's why I say it's not an organization trying to raise money, it's not even a formal organization, it's just bringing more people together. And just at this meeting, several of the anesthesiologists are interested in getting involved in this as well.
Yeah, the multidisciplinary approach is
that's
important. As the world enters the third year of COVID-19 pandemic, doctors face more and more complex neurological cases. What are the most relevant issues to be addressed in the future?
Well, clearly the situation is so different now than it was in March of 2020 or April. Before there were vaccines, people were dying in huge numbers. And now, I think one big issue is getting people vaccinated. I think it's much less of a problem in general in Europe. The US, there seems to be this group of 20 or 30% of the population is just, for some reason, become anti-vaccine, even though 20 or 30 years ago they were getting polio and yellow fever. There's all sorts of vaccines that have been developed. The smallpox, for example. So one is just getting as many people around the world vaccinated, and then the kind of a corollary of that is the updated vaccines. I know there's a new version just come out, getting that particularly into the high-risk people. So, and I could say probably the other big issue, and I'm sure Professor Marciano and others here are very interested in this, what they call long COVID. The fact that there's a significant number of people that, you get a flu and, you feel lousy for a couple of weeks and then you're fine. There's a significant portion of people with COVID that aren't fine and they can't get back to work. So that's an area we really need to focus on too.
All right. And my last question refers to health expenditure. So the US has quite high health expenditure, almost 4 times more than Romania as percent of GDP. How do you see the use of neuroprotective agents in low and middle income countries? Well,
I think you don't follow the US example. And I mentioned, actually it's Lord Nigel Crisp was one who was head of the National Health Service in the UK. And since then, and he's published 3 or 4 books over the last 15 years or so, he's gone to a combination of the lower middle income countries, sub-Saharan Africa and India, working with nursing, which is usually kind of the front line of healthcare, amazing techniques for providing efficient, cost-effective healthcare. The opposite of the US, where every new development is it's more high-tech, it's more expensive, because the companies are trying to make a profit. I mean, we've gotten away in the US, away from healthcare being a right to, yeah, you got to pay for it. So, just an interesting aside, in 2018, I was invited by some European colleagues to the St. Petersburg International Economic Forum, which nobody in the US knows about, but I think everybody in Europe knows about, although given what's happening in Ukraine and Russia, I'm not sure what will happen in the future. But there was a panel that was headed by the Minister of Health, who's a neurologist, and she's a very bright woman. And I was going to give a little talk on sort of like this. And the first thing they asked me was about healthcare in the US. And I basically was giving all the reasons you don't want to use that as a model. I mean, it's profit driven. So what somebody like Lord Nigel Crisp is doing is what we need to do is go around and look. In Kenya, for example, one example is they have developed cell phone apps, because everybody has cell phones, to coordinate prenatal and postnatal care for pregnant women with the taxi services, which are usually motorbikes, to get them to appointments, to just facilitate all that. And if they have, around the time of birth, if it looks like a complication, again, they get people to the hospital immediately. And so you can take something, everybody's got a cell phone, and so they're very creative about apps like that for healthcare. So it's just one example of where they're doing things in Kenya that I don't think they're doing in the US. I don't mean, there's no specific program like that to improve maternal, the period around childbirth.
All right.
So,
thank you very much for
thank
the
you.
interview.
It's always a pleasure to, I think it's probably my 4th visit to Cluj, and anytime, just give me an invitation. I love it here.
Yes.
Thank you.
Maybe the next year for the next IGNA conference.
Well, whenever, whenever there's, leave it to Professor Marciano. He's an amazing fellow.
We're glad.
Well, thank you.